Done. Done. Okay, sir, it's done, so you can start maybe. Sorry, we are a little late, but
No, it's okay.
okay, sir, you start, please.
So, good afternoon, everyone. Is the echo coming?
Mic on, कब कर दो. Sir, speak again.
Hello? Yeah, echo is still coming.
From this side seems okay.
Shall I re-log in?
We can hear you without echo. This side is okay.
So, good afternoon, everyone. And today we will discuss about basic MRI pulse sequences. And last lecture, we discussed about how to get image. But this is irritating. Let me disconnect and connect again.
It's not moving, looks like. Okay.
It's held up somewhere.
It's completely gone.
Hello?
Yes, sir.
Lot of echo coming.
Still echo is coming that side.
Yeah, let me
Yeah, Professor Khushio, is there any problem, sir?
Left is
Hmm?
sir left or अभी just
I think he's trying to reconnect. Maybe we have to let him in now. He'll record. लिंक तो कनेक्ट हुआ था ना फिर सर कुछ बोलो कि रिकनेक्ट करते हैं टेक्स्ट किया है उन्होंने को पूछ तो नया लिंक भेजना चाहिए क्या रोहित है क्या अभी तो मीटिंग में था
फोन उठाए मैं बोल नहीं ऐसे यहाँ से तो कोई इशू नहीं है को आ रहा है इसमें।
ये कौन सा चले वेब एक्स ना ये यूट्यूब में देखो तो क्या सिचुएशन है
ये वेबएक्स से कनेक्ट है ना सर तो
अच्छा वेब एक्स में नहीं है तो उधर भी नहीं आएगा
नहीं आप फोन पे सुन सकते हैं वैसा हो सकता
hello yeah you got connected then what happened again it's not connecting okay let us send a new link just I ask my IT person if you can send it okay just wait sir उन्होंने को बोलो न्यू लिंक वो लिंक में कुछ इशू हो रहा है
है सर अभी न्यू लिंक क्रिएट करेंगे फिर स्टूडेंट्स
हाँ?
न्यू
वो सेम लिंक भेजने के लिए बोलो ना लिंक को ईमेल करने के लिए hello sir
Can you hear me?
yeah so you got connected now
Okay, yeah.
yeah yes you start
Okay, good. Am I audible?
yes sir please go ahead
Okay, so last lecture we discussed how do we apply the magnetic field gradients to spatially encode the signal to form an image. So we discuss the gradients are the gradient magnetic fields are the magnetic fields which are varying with distance, and they can be superimposed on the static magnetic field so that the each location along the axis of the magnetic field can be made to have variable fields, localized fields, so that they have different resonance frequencies, and hence we can do this slicing on the body. So in this picture we have shown how on the right hand side the field is this is a gradient, magnetic field gradient. And you can see the magnetic field is increasing in this direction and decreasing in this direction. So that means on the top of the B naught, near the B naught, this area, the magnetic field will be maximum, and here it will be minimum, and in the between there will be a gradation of the magnetic fields, and so all these points will have different resonance frequencies. And we also discussed that if we have two test tubes and we make a NMR spectrum from this, you will get a single peak, single FID, and when you Fourier transform, you get a single peak. But if you apply a magnetic field gradient, so that the frequency, the magnetic field seen by the two test tube is different, so they will have different Lambda frequencies or the resonance frequencies. So when you Fourier transform this, you will have two peaks corresponding to each, test tube. So that means you have resolved the signal in one direction. Then similarly, if you have a big gradient, a big phantom of water, and you apply a gradient magnetic field, you can make compartments of this phantom, so that from each compartment you have a signal, individual signal from each compartment. So that means by applying a gradient, you can slice the object depending on the slice thickness, whatever you want, and that will depend upon the slope of the magnetic field gradient. If the magnetic field gradient slope is high, it's a very steep gradient, you can cut thinner slices. If gradient is not so slopy, then you will get a thicker slices. This is how you can manipulate with the slice thicknesses while you apply the gradients. And then we also discuss to create an image, we have to apply 3 identical and orthogonal gradients, and these gradients are denoted by slice selection gradient, frequency encoding gradient or readout gradient, and the phase encoding gradient. And we also discussed that these gradients change their roles according to slice orientation. That means if you have an axial slice, Z slice, then X and Y will act as a phase encoding and frequency encoding gradient. Similar wise in other orientations. So to form an image, first slice selection gradient is applied to cut a slice out of the volume. Then subsequently apply phase encoding and frequency encoding gradients, so that you can actually have a very distinguishable signal from each pixel on the image. So here I have shown we applied a slice selection gradient. You have cut so many slices, and you can see on the first slice all the pixels. There are 3x3 image. Suppose this is a 3x3 image. So on this image, on this plane, all the pixels have same frequency and phase combinations. So that means they are not distinguishable from each other. So what we have to do, we have to apply the 2 more gradients in X and Y direction, so that each pixel in this image have a very distinct frequency and phase combination. How do we do that? By applying a 2 more gradients in 2 other orientations, the frequency encoding and the phase encoding. And if you see at this pixel, look at this pixel. This pixel has a unique frequency and phase combination, and all pixels along this column will have the same frequency, but they will have different phases. Okay, so that by applying these 2 gradients, you can see all pixels on this image will have a different phase and frequency combination, and which can be characterized by after doing the Fourier transform. One more picture I am showing, there where we have 2 pixels A and B, and then this A and B have same frequency omega, but they have different phases. So this is omega phi B, this is omega phi A. So they have 2 distant pixels with different phase frequency combinations. They are distinguishable on the image after Fourier transformation. So here we have shown if there's a 5x5 matrix, so all the 5x5 elements, 25 elements, have a different F1, phi1, F2, phi1, F3, phi1. So all pixels on this image have different combinations. So they will be distinguishable when we form an image. So this is how you cut a slice and then apply frequency encoding and the phase encoding gradient to form the image. Then we also discussed, this is a case space. This is every 1 TR, you are calculating one Fourier line. So if you have 256 by 256 matrix for the image, so you have to apply this phase encoding gradient 256 times like this. One by one Fourier line will be excited, and you can, after you finish the acquisition, then you can Fourier transform and form the image. So this is shown here. This is a case-based data, which is the frequency phase combination data. When you Fourier transform, you see the image. So this is like revising what we discussed in the last lecture about how to, especially encode the NMR signal for the imaging. Now, today our topic is MRI pulse sequences. That means, and pulse sequence is a program, it's a timing program which decides which all gradients, which RF pulses are to be applied at what moment of time and when they are to be switched off. So now we are very clear that to form an image, you need a static magnetic field, which is V naught. Then you need another magnetic field, which is the radio frequency magnetic field, which is 90-degree pulse and 180-degree pulse, which we call as B1 in NMR. So you are applying V naught, you are applying B1, then you are also applying 3 gradient magnetic fields, GX, GY, and GZ. So these are 5 magnetic fields which you are applying simultaneously to form an image. Now, in the temporal domain, when to apply which, the static magnetic field is always on. And in the temporal domain, when to apply 90-degree pulse, when to apply 180-degree pulse, when to apply slasher gradient, this is decided by a program which is called MRI pulse sequence. So, and each sequence will have a number of parameters which can be varied to produce specific contrast. By changing the pulse sequence, you can make the image to look dominated by a particular contrast. So, how we do this? This will come into the subsequent slides. And then all these pulse sequences are packaged into MRI protocol for the clinicians or for the scientists, so that he can acquire these images one after the other to complete the data acquisition. So there are several pulse sequences in NMR. The most basic pulse sequence is free induction decay, and I have put present steam to more pulse sequences which are essentially used in MR spectroscopy. But as far as imaging is concerned, the spin echo is the main workhorse of the imaging work. Then came gradient echo, then inversion recovery, the turbo gradient spin echo, turbo spin echo, and the fastest technique which we are using for functional MRI and other techniques is echoplanar imaging or EPI. So these are the pulse sequences which are very common when you look at the MRI, and most of the pulse sequences are made combination of these individual pulse sequences to get the benefit of your measurements. So the first pulse sequence is, like we said, FID. FID is nothing like a 90-degree pulse. You apply a 90-degree pulse. So you have a situation like this. When you apply B naught, sample is in the magnetic field. There's a M naught built up in Z direction, the direction of the magnetic field. You are applying a 90-degree pulse. By applying a 90-degree pulse, you are flipping this M naught to MXY plane. And after some time, MXY plane, these spins dephase out because of the intrinsic T2 and also because of the inhomogeneities in the magnetic field. These spins will dephase out, and a coil will sense this change in magnetization, and a signal will be induced, which is this signal FID. And when you Fourier transform this, you get a signal from this particular sample. And if you have several samples, and if you apply magnetic field gradient, you can have several these signals from different locations. But FID is essentially not used in imaging. It is a spectroscopy sequence, and it's used only in spectroscopic measurements. So the FID, one important thing I want to tell you about the FID, longer the FID, that means the long is G2 and better is the homogeneity of the magnet. So this FID shape, what you see here, it's a long FID, slowly decaying FID. That means whatever is the material from which this FID is coming, it has a very long T2. And longer the FID, better you will have signal. So you can, after you Fourier transform the FID signal, you get a peak like this. So then these are peak characteristics. This is a resonance frequency at which the peak is coming, then peak amplitude, and gives you the idea about the concentration of that particular nuclei in the sample. So if the concentration of the material is more, you will have a higher peak or the higher peak area. Then FWH is the full width half maximum. This gives you idea about the homogeneity of the magnetic field and also of the T2 of the material or the of the element. Say this is a peak sample from a human tissue. So you can see there's a big peak from the water here, and then there's a small peak from the fat. So both the peaks are very well visualized in this spectrum when you do a FID pulse sequence. The second pulse sequence, which is the main, the 90% of the work is done using spin echo imaging pulse sequences. So here what you do, you are applying the structure of the pulse sequence is like this. you apply a 90-degree RF pulse, and along with this 90-degree RF pulse, you are applying a slice selection gradient. That means by this applying this, you have selected a particular slice, and that slice is being excited by a 90-degree pulse. Now you can acquire signal soon after the 90-degree pulse, but when the transmission of RF pulse is on, you cannot switch on the receiver, and when you have to wait for some time to switch on the receiver, so most of the signal will decay out. So it is better to acquire a echo rather than FID. You know, when we loudly speak into a hall, you hear an echo. So similar way, 180-degree pulse forms an echo on the signal. So you apply a 90-degree pulse and slice selection gradient. That means one slice has been selected and it has been the magnetization has been flipped to XY plane. Then after some time, these magnetization will decay out like it was done in FID. Then you apply 180-degree pulse. All these dephasing nuclei will rephase again in the other orientation, and then you can acquire an echo like it is shown here. So you can have a full signal, acquisition of full signal. So these echoes are like two FIDs back to back. So you have a very strong signal if you do a spin echo. And we also discussed last time that the time between first 90-degree pulse and the acquisition of the signal is called echo time. Okay, and then you are applying a slice gradient. Then you apply a phase encoding step and then frequency encoding gradient, and you acquire one Fourier line. And this phase encoding gradient, this whole cycle is repeated in n number of times depending on the matrix size. If matrix is 256 by 256, you will have to apply phase encoding gradient 256 times. So this will, you will acquire one Fourier line, then increase the phase encoding gradient little bit, and then apply again, and keep on applying, acquiring this signal 256 times to acquire a complete image data. And the difference between the first RF pulse, 90-degree pulse, and the second RF pulse for the Fourier line is called TR, the repetition time. So these are the two terminologies which are very important to decide the contrast in the MR images. So this is a complete pulse sequence of spin echo where everything has been decided: when to apply 90-degree pulse, when to apply slice gradient, when to apply 180-degree pulse, when to acquire the signal, when to apply the phase encoding gradient, when to apply the frequency encoding or the readout gradient. This is a scheme, complete scheme. This is a complete program, and this is run automatically, and the gradients are switched on and off automatically while measurement is on. So this is a little simplified of spin echo, and one has to be very sure that this 180-degree pulse has to be in center of the 90-degree pulse and the when you acquire the echo, so that echo is symmetrical. If this is not centrally placed, 180-degree pulse is not centrally placed, then you will have a asymmetrical echo. You will have one side echo will be less, other side echo will be more. So you have to see that you have 90-degree pulse and 100-degree pulse t by 2 times, t by 2 time, time apart, so that you have symmetrical echo on the image. So this is how this is a complete pulse sequence. You can see these are several phase encoding gradient steps which you apply one after the other and then acquire the whole image. So this is how the acquisition is done. First Fourier line, when you apply the first phase encoding gradient, you increase the phase encoding gradient, acquire the second line, acquire the third, fourth, fifth, and go on acquiring the different lines depending on the matrix size. So this is how the 2D Fourier acquisition is done. So, and there's a mathematics behind this, the contrast in the spin echo. This signal in spin echo is a function of TR and TE. This is a function which is proton density. That means number of protons which are available in the sample. This is a T1 combination. This is a T1 factor. This is a T2 factor. And depending on the magnitude of TR and TE, you can make the signal to be dominated by proton density or T2 or T1. So then we call the proton density weighted image, T1 weighted image, or the T2 weighted image. So when T is made short compared to T2, the ratio of T by T2 approaches 0. So the T2 weighing terms approaches 1. In other words, T2 effects largely disappear. So you will have a only T1 weighted contrast. So similar ways you manipulate these parameters, TR and TE, you can exactly create an image which will be purely proton density image, purely a T1 weighted image or a pure T2 weighted image, depending on the what image contrast you desire. So this is a very simplified method of spin echo contrast. And if you have a short TR and short TE combination, then you have T1 contrast, you can get a T1 image. If you have a short TE and long TR, you get a proton density contrast. You can see the proton density image. All these pixels in this image will be dominated by the proton density parameter. Here, every pixel is a depiction of the T1 relaxation time of that tissue. And when you have long TR and long TE, you get a T2 contrast where each pixel on the image gives you the T2 relaxation time. And this is again I have shown these are the T1 and T2 times of different tissues in the brain or in the body. And CSF, blood, water, white matter, gray matter, all have different T1 and T2 times. So they are distinguishable. And this is a T1 image. You can see CSF, these ventricles is dark here. And same CSF becomes bright when you are looking at the T2 image, T2 weighted image, because T2 of CSF is long, so you see a bright signal on T2. CSF T1 is long, so you see a dark signal on the T1 image of the CSF. So this is how you can distinguish different constituents in the brain or in the tissues. So here again you have a tumor. You can see T1 weighted sagittal image. Then here tumor is dark in T1 and then it becomes bright in T2 weighted images because T2 and the edema has long T2, so you see a bright signal from the tumor. So the advantages of spin echo is it has a very good signal to noise ratio. It has high signal to noise ratio, so it is very much preferred, and it gives a very good T2 contrast. That means it can create a very good T2 weighted image so that you can identify the pathology very easily. And it is least artifact prone sequence. Most of these sequences give you a lot of artifacts, but in spin echo gives the least artifacts. So you are sure that what you see is actually the signal, not the false, false representation of the tissues. Then contrast mechanism, as I said, is easier to understand because it's only TR and TE which are determining the contrast. The disadvantages of spin echo is high SAR. SAR is specific absorption rate. You are pumping in a lot of radio frequency energy into the patient. So there may be a tissue heating because when you pump in too much of radio frequency pulses in terms of RF power, there could be a power deposition in the body. So you cannot use spin echo in 3D mode because you are going to pump in lot of power into the patient, which can be dangerous. So and second disadvantage of spin echo is you have to use a long TR times because you are giving a flip angle of 90 degree and you have to wait for relaxation to complete so that you again have MZ back to M0 levels. So you have to use a higher TR. So 3D acquisition is not possible to take few hours to acquire a 3D image using spin echo. So based on these, the spin echo was modified, and then Jens Fram from Göttingen University, he modified the spin echo pulse sequence to make it much faster. So what he did, he replaced the 90-degree pulse by a 100 alpha pulse, which is from 0 to 90 degree. It is not 90 degree. It can be any degree from 0 to 90. We call it alpha pulse, and rest of the pulse sequence is same. There is no change in the pulse sequence otherwise, except this alpha pulse. And also instead of 180-degree pulse, we are using a gradient reversal. You can see the readout gradient is bipolar. It is going negative first and then becoming positive. So this effect, when it goes from negative to positive, it does the job of a 180-degree pulse. So here what we have done now, we have replaced almost both the RF pulses with much milder pulses, that is the alpha pulse, and then 180-degree pulse has been all completely taken out. So what happens otherwise, the way pulse is applied, slashing gradient is applied, phase encoding is applied, everything is ditto same. There's no difference except these two differences. Instead of 90-degree pulse, you are applying alpha pulse, and instead of 180-degree pulse, you are doing a gradient refocusing. You are applying a readout gradient in both directions, negative and positive direction, so that the echo can be refocused. And this signal in gradient echo is a function of TR, T and alpha. Alpha is the flip angle by which you are tilting the MZ magnetization into XY plane. If you are doing alpha of 10 degree, then we say flip angle is 10 degree. If you flip by 20 degree, then flip angle is 20 degree. Likewise, you can do any flip angle and then acquire the MR images. And here, if you look at the equation down below, if you put alpha as 90, then this will collapse into a spin echo contrast. You can see if alpha is 90, then sin alpha is 1, cos alpha is 0. So this will collapse into a spin echo equation, which we saw in the last slide. So here the function, the T1 and T2 contrast, T1 and T2 weighted images, you need to manipulate 3 parameters instead of only TR and TE. You will also have to manipulate alpha pulse, so that you can manipulate the contrast. So what happens? So this is the equation for the scenario for contrasting gradient echo. When you have a long TR and large tip angles, mean large flip angles, you can see short TR and large tip angles on large tip angles, and short TE will give you T1 contrast, and long TR and short TE will give you a proton density contrast on large tip angles. But if you have smaller tip angles, you will have a proton density image. When you have short TR and short TE, you get a proton density image. When you have long TR and short TE, you also get again proton density image. If you have long TR and long TE and short TR, you get a T2 star contrast. And one more thing is there, as I said, the spin echo will give you a T2 contrast. The gradient echo doesn't account for the inhomogeneities in the magnetic field and the susceptibilities in the tissues. So we call it a T2 star contrast. So in spin echo, you get a T2 contrast, T2 weighted image. In gradient echo, you get a T2 star weighted image. So this is the basic difference between the two. So you can see, so advantages of gradient echo is faster imaging with T2 star contrast, can use shorter TR and shorter TEs than spin echo. That means you can pulse faster, you can make TRs very short, and the measurement time will be much lesser than the spin echo. And now since you are applying low Philip angle RF pulses, so the RF deposits will be very small, and you can have more slices per TR and then spin echo. So SAR is decreased. The power deposition in the tissues is much less in gradient echo than in spin echo. The disadvantages of gradient echo is it's difficult to generate good T2 weighing, because I said you will get a T2 star contrast, and sometimes it becomes a nuisance on the images when you want to see a T2 contrast and you're seeing a T2 star contrast. You can be misled unless you know exactly what's happening in that tissue. Then magnetic field inhomogeneities cause signal loss, and when you have long T times, it worsens up. The signal drops very fast, and then there could be susceptibility artifacts in the images if you are not interested in looking at that. And then you can also have dephasing of water and fat protons. That means you may see a fat and water interfaces over the images sometimes, which are not desirable. So this is the comparison. You can see look at this. So the two pulse sequences kept side by side, and the only difference is here you have pi by 2 pulse, here you have alpha pulse, and there pi pulse is not there in this. This is only a gradient reversal. So this is the on snapshot of the differences between spin echo and gradient echo. So now T2 weighing is in gradient echo sequence, as I told you, is called T2 star weighing. We don't, when we do a gradient echo acquisition, we don't say T2 weighing, we say T2 star weighing, because it is including the effects of the magnetic inhomogeneity as well as the susceptibility of the tissues. So they are very important, parameter T2 star are very important when you are doing functional imaging and the diffusion weighted images, where you don't want to eliminate the effects of the magnetic inhomogeneities and the susceptibility of the tissues. So here you can see these are the graphs of T2. T2 is the longest, and when your T2 star in good magnet, and if your magnetic field is very well homogenized, you can produce very nice T2 star images, because the effects of that the loss of signal due to magnetic inhomogeneities can be eliminated by doing a shimming on the magnet, by producing a very homogeneous magnetic field. So you can see here the T2 graph of a true T2 is very long. When you have a good magnet, it is still longer. But if you have poor homogeneity, T2 can drop very fast, and this can cause losses in the signal. So this is a well-shaped magnet, and the poorly shaped magnet, you can see the difference in the image quality. This is more grainy than this image, and they are all, both the images are T2 star images. So these are the T2 curves of the different pathological conditions. This is CSF, the gray matter, the white matter, and if you have some pathology, you can see the graph will be somewhere in between, which will be intensities will be higher than the gray matter and the white matter, and slightly less than the CSF, which is a free flowing liquid. So this is how the different tissues will show their T2 characteristics. So then you can also have multiple spin echo and multiple fast spin echoes, depending on, instead of applying only 180-degree pulse, you can keep applying 180-degree pulse again and again, and you can acquire so many echoes from the same pulse sequence. So this is called fast spin echo, the multiple echoes, and within the same TR, you can acquire multiple, pulses, multiple echoes, and acquire the image corresponding to each echo time. And these echo times can be utilized, these images can be utilized to calculate pure T2 image. What we are acquiring through spin echo is a T2 weighted image, but if you want exactly each pixel should give you T2 reduction time of the tissue, so you have to calculate T2 image, which is done by multiple T values, images with multiple T values. You can calculate the pure T2 of the tissue or the image. Then next sequence, which is very commonly used, is inversion recovery. So this is a 90-degree, this spin echo, what you saw, 90-degree pulse, then 180-degree pulse, and then you acquire the signal. In inversion recovery, what we do, instead of 90-degree pulse as the first pulse, we apply a 180-degree pulse. Okay, so what it does, it brings the magnetism from MZ to minus MZ direction. Then you give some waiting time, which is called inversion time. Here it is given, it is the inversion time. You wait for some time. The nuclei which have shorter T1 times, they will relax faster and come to the positive Z direction. Then you can apply 90-degree pulse. You can bring them to XY plane and then acquire the signal. So 90-degree, all the tissues which have longer T1 times, they will take longer to relax and come to the positive MZ direction. So you can here, by applying inversion recovery, you can have selective excitation of the different components of the tissues. So like you have this is a different TI times, you can see here, TI 180 millisecond, TI 400 millisecond, TI 2500 milliseconds. Here TI 100 milliseconds, you have suppressed the fat. You can see the outer rim, outer bright rim of the image is not seen here, because you have suppressed the fat. Fat has been suppressed completely. So T1 TI of 400 milliseconds, white matter has been suppressed. Okay, and depending on, by choosing your TI value, you can suppress any component of the brain selectively depending on what you want to see. If you want to see a fat only, if you want to see a tissue only, you want to see a CSF only, you want to see a white matter only, according to that, if you know their T1 resident times, you can set your TI accordingly and create an image which will look like these. And this is the TI of 2500 milliseconds. Here CSF has been suppressed. You can see how this should have been very bright signal from CSF, bright white signal, but yet it has been suppressed now. So you see a dark signal from the CSF. You can see here completely. Here the gray matter has been nulled. Gray matter has been suppressed. Here CSF has been suppressed. It is dark here CSF. Here fat has been suppressed. You don't see outer layer. What you see here, outer layer, bright ring here, which is not seen in this image because fat has been nulled. And in this case, white matter has been suppressed. So depending on your TI time, you can suppress any tissue in the brain to look at the pathologies in a much better way. So this is a fluid attenuated inversion recovery spin echo. So this is a spin echo. This is T2 weighted. You can see every place where fluid is there, you see a bright signals. But this is a fluid attenuated. Here the fluid has been suppressed. So you can see where whatever is bright here has become dark. Where your fluid has become dark here because fluid has been suppressed by inversion recovery sequence. So this is sometimes very useful when you want to look at the tumors and other issues where you don't want to look at the fluid, you want to suppress the fluid and see the etiology around that area. So very useful sequences for medical diagnosis and for research. So the disadvantages of inversion recoveries, they are longer scan times, they increase in flow related artifacts, and this timings increase there, and signal to noise ratio can decrease as tissues are suppressed, and it has high specific absorption rate due to additional 180-degree pulses. But it has certainly advantage that you can fine tune your contrast. You can suppress any tissue in the brain or in your examination. Whatever you want to see, you can see accordingly. So that is the advantage of this. Otherwise, it has a very high SAR. So generally, it is used only for good T1 contrast and the tissue suppression techniques. These IR sequences are used. Then this is the last pulse sequence, which is being very commonly used in advanced imaging techniques. This is called echopulmonary imaging. This technique was developed by Sir Peter Mansfield in 1977. You can imagine, but this was applicable. This was actually in practice came only in late 90s because this required a very very strong, very robust hardware, NMR hardware to run these sequences on MRI scanners. So and Sir Peter Mansfield got Nobel Prizes for physics along with another gentleman. They both got a Nobel Prize for the MR imaging, and this sequence is very interesting. You can see here you just apply 190-degree alpha pulse, and then you have this is GY is phase encoding gradients. You have small blips, very sharp pulses of phase encoding gradient. You can see here, and then you have a gradient reversal, like you have gradient echo to acquire the signal. You have a reversal of gradients, negative to positive, and you keep on acquiring. And then in this case, in one alpha pulse, you can acquire the whole K space. Like it goes from left to right, right to left, left to right. In the one go, the whole image is acquired, and this is a great saving in the measurement time. You can acquire the whole brain within few seconds, and it's very good sequence for neonatal imaging where the small baby cannot hold his head for a longer time without movement. So you can do a snapshot imaging using echopulmonary imaging because you can actually acquire images in a millisecond time domain. So then then you can also depending on the hardware robustness of the hardware, you can acquire this image in one single shot as I showed you now, and some robust, it's not so fast, so you can also acquire EPI in multi-shot mode. Here you in the left hand side you can see this is a single shot, all are being acquired in one alpha pulse. But multi-shot you can acquire, suppose you have to acquire 256 lines, you can acquire 64 lines 4 times. So this is called multi-shot, and if you use a one shot, then it is single shot API. If you are using two times the whole image is acquired, you can say double shot, and if it is done in multiple shots, then you call it multi-shot API, depending on the how fast your hardware can work. So then Then you have signal characteristics, on the image, on the T1 and T2 weighted images, and signal intensity will be high. Fat will be high on T1. Hemangioma will be high on T1. Intravenous lipoma will be high. Radiation changes, degeneration, fatty deposition, cyst and proteinous fluid, paramagnetic contrast agent will be all showing high intensity on the T1 weighted images. And on the T2 image weighted images, water, edema, whatever is free fluid will show bright on the T2 weighted images. These are some of the examples which are showing here. What will show bright and what will show dark on MR images is shown here. Then low signal intensity will be shown by cortical bone, avascular necrosis, infection, tumors, sclerosis, cysts in T1 weighted images, and on T2 images cortical bone, bone island, deoxyhemoglobin, hemosiderin, calcification, and T2 paramagnetic agent will be shown low intensity, or on the darker in the images. And there will be no signal from air on T1, fast flowing blood, tendons, scar tissue, cortical bone and calcifications. Low flowing blood will have no signal on T1, and on T2 air will have no signal. Fast flowing blood will have no signal. Tendons will don't have signal. Cortical bone and calcifications and scar tissue, they will not show any signal on T2 weighted image. This is essentially for people who want to make diagnosis when they don't see they see a low signal or high signal on T1 or T2 weighted images. They must understand what is going on in the tissue and what type of tissues they are dealing with. So summary points are all intrinsic contrast parameters contribute to image contrast, and which we will show in next lecture how manipulating contrast can be manipulated by changing the sequence parameter, which what we saw here, how you change the parameters and acquire a particular contrast. Then extrinsic contrast parameters used to control how much influence each intrinsic parameter has on image contrast. And now we know TR controls T1 and T controls T2. See, the TR will have always effect on T1, image, and T will control the T2 weighted images. And to produce T1 weighted image, it is necessary to create contrast in which the difference in the T1 recovery times of the tissue dominate image contrast. So that in the two tissues, the T1 difference should be too much, so that they can be very well distinguishable on the T2 weighted image. Similar way, to produce a T2 weighted image, it is necessary to create contrast in which the difference in the T2 decay times of the tissue dominate image contrast. These are some of the points which we must know. A long TR combined with a long TE produces a T2 contrast, and a long TR and short TE produces proton density contrast. This we have discussed just now. And T1 weighted images are used for anatomy and pathology post contrast enhancement. T2 weighted images are used for pathology. So if you are suspecting some pathology which is not very well visualized on T1 weighted contrast, so you have to inject a contrast agent, so that this pathology can show enhancement on the T1 weighted image. Proton density images are used for both anatomy and pathology, but they don't have much of clinical significance, because they don't really give any different information when you do the diagnosis. So this is for today. I had this kept in mind, and you will have thousands of pulse sequences which are in practice in the clinics and in the research setup. All these pulse sequences are combination of these pulse sequences, spin echoes, then gradient echo and spin echo combined, then inversion gradient echo. Likewise, you keep on playing with the parameters. If you know good physics, NMR physics, you can produce newer pulse sequences to create newer contrast mechanisms to facilitate the better diagnosis. So this ends the today's lecture on pulse sequences, and next lecture we'll have on the image parameters and how image quality is improved by playing with the different image parameters, which can be intrinsic or the extrinsic parameters. So this is the end of today's talk. If you have any questions or doubts, please you can raise.
Yes, participants, if any questions you can please ask. Sir will be happy to answer.
I hope they are participants.
Yeah, they are not responding anyway.
But
So
are they
some-
there?
Yeah, they are there, but normally they are not asking as such.
Okay.
Okay, sir. This reading materials you told you will send something.
Yeah, I think now this, after covering this, I can
Okay.
send one shot.
Yeah, fine. And one book you suggested, no, you'll if you can give the link or something maybe.
I
You
can
suggest
send it.
one book sometimes in the first class.
Sorry, say it again.
You suggested one book. You will give the link.
Yeah. That also I will send it. Yeah, sorry,
Yeah. So that
I
students
forgot
can
that.
follow a little bit. I think they need a reading something
I will. Yeah.
because this is really a new topic for all of them. No, so they need to read little bit before asking something. I think.
Yeah, I think that will be good for them. Yeah.
Yeah.
I will
Please.
do that. I will do
Okay.
that. And tell me one thing.
Yeah.
Monday I have some commitment. How can we adjust?
Monday means you would like to change the date in that case or two ways.
How can it be done without affecting much of your schedule?
No, in that case, I have to just maybe just give me the time. Monday whole day you are busy or something.
Actually, I will be going somewhere. I don't know whether I will reach home by 3:30. I'm not very sure about it.
Should we miss time wise? Should we postpone by maybe half an hour or 1 hour? Is it okay?
So okay, do one thing. I will do one thing then. I don't know how good will be the connection there. Otherwise, I can do it there itself and come back. But I'm not very sure about the connection. I will try to find out if I get a good connection over there.
Okay, sir. I'll Tuesday there is a class.
Tuesday.
That material chemistry class is there, no?
What is this?
Tuesday.
Okay. Don't disturb your schedule. I will see. I will.
Otherwise, sir, one option is there. Maybe we can skip one class, and after this one, we have 1 or 2 weeks free time. There we can accommodate one class.
Half an hour.
Huh?
30 minutes you can extend. No?
Or otherwise, next 2 classes we can extend half an hour, so can adjust that.
Yeah, I can take 2 hours on Wednesday.
1.5 hour or 2 hours you can take at a stage.
Yeah, I can do that.
Okay, then Monday we can cancel the class.
Sorry, I have to go very far and there's a meeting. I don't know whether I will be able to reach by 3:30.
Better don't take any risk. Or, then Monday class let us drop this one. Wednesday maybe you can extend little bit. Wednesday and Friday.
Okay.
That is okay, sir.
Thank you so much.
All right. Then Monday we don't have a class. Wednesday and Friday will make it little extended class.
Only this week.
Only this week, okay.
Yeah. Sorry for the trouble.
No problem. It's, we are traveling you, sir. I'm really sorry, but we need to make the things as comfortable to you as well as participants.
Today I will try to send this PDF and as well as that book.
Okay.
Thank you so much.
Okay. Thank you, sir. Thank you very much.